I'm Florence Comite. I've been at these conferences now for, well, I think almost since they started. Maybe not the first one, but shortly thereafter, so 7 years. And we've grown amazingly by leaps and bounds, and I'm very excited today because I think this is a major leap forward in what we're going to be able to do in the future to help proactively treat and manage our patients before they get sick, because it's the world of genomics that we're entering now. And you could say I've been preparing for this my entire career, in that when I graduated from Yale Medical School, I remember my dad asking me a question and stopping me in my tracks. He said, "Okay, now that you've graduated, Florence, can you tell me how to stay healthy?" And I was completely bewildered, because in medical school what we really learn is how to treat disease. We don't really learn how to stay healthy. Since then, I've focused what I do, my practice and my research, on a field that's emerging called precision medicine. And it's a perfect fit for age management, in that in age management medicine, we want to prevent disorders of aging. Notice I say disorders, not diseases. And to that end, that's what we can do. We collect all this information on our patients, from metabolic to hormonal information, lifestyle. And at this moment in time, we're going to be looking at genetic profiles. The field is ready for us, and I think we're on the verge of starting it. And there are very few doctors in this country or in the world who've begun to incorporate genetics into clinical medicine. It's not really ready for prime time, in that you can't use genes for everything in medicine, which is an erroneous idea I had 20 years ago, waiting for genomics. But you can use it to contribute, and I'm going to share one of the slides I have before I introduce Erica. But I truly believe we can make our health span last a lifetime for ourselves and our patients. And I think many of us are driven by what we see are the failures in medicine, the fact that we're sustaining people at the end of their life who are not well. And just imagine a world where all of us could be well until the very last minute that we take our last breath, get a little tired out, go to sleep, and don't wake up, but feel well. Let me move to slide. What I wanted to share today is this recent study. It's so recent, it just came out last week in the Science of Translational Medicine. And the author of it, the key author, he's the last author on the paper, is Dudley at Mount Sinai School of Medicine. And this is a perfect example of the world we're beginning to see emerge. And that is, they were able to study many thousands, over 11,000 individuals, to show that type 2 diabetes is at the very least 3 different subsets of diseases that relate to different issues, whether it's cardiovascular or it's cancer. It's not the same disease across the genome. And the expression of disease and what a diabetic would have to face in their lifetime is dependent on their genetic makeup. And so the more we learn about this field and where genetics is taking us, I think the more we realize that we'll be able to fine-tune what we do for each individual and selectively manage and treat, whether it's lifestyle or supplements or medication, to prevent the devastating disease that we see in diabetes. One of the primary reasons that drove me into the field as well, because as an endocrinologist, I really dislike the disease. It's a disease that you can detect decades before we actually get symptomatic, and yet most of the way we practice in this country is the disease has to emerge in order for that to happen. The last slide I want to share just shows these different groups. It's part of this paper. I'll be happy for anybody who comes up to give you the exact reference, which is on the second slide, or send these slides to you. But what you see here on this figure are 3 different colored circles, and they relate to the different SNPs on the genome, and I'll let Erica Ramos talk you through that. But basically, the changes confer different expression of diabetes So all the diseases that we're confused about, do we tightly manage it, do we not, do we see microvascular disease, do we get strokes or heart attack or kidney disease, how about neuropathies or any of these other disorders related to diabetes actually can be specific to the type 2 diabetic. And I think that while this is just the beginning of the floodgates opening, I think there are many other practices out there, from asthma to neuroendocrine diseases to neurological disorders, that will allow us to do the same thing. So with that said, I'd like to introduce Erica Ramos, who's a clinical genetic counselor in the Applied Genetics Division of Illumina, and she will be happy to walk you through understanding your genome and the program that will allow you to look into yourself and understand how you're going to apply it in your practice, should you choose to go forward, which, you know, I think is the sign of the future. Thank you.
All right, thank you so much, everyone. It's really a pleasure to be here and to talk to you a bit more about something that I'm extremely passionate about and really enjoy, which is genomics, and most specifically really using genomics in a healthy population, which I think is really what's most applicable to all of you. I am going to talk really at a high level about our program, what we found in our program, and really hopefully get you excited about the idea of getting your own genome sequenced and really looking at how you can use your own genome to really inform what you want to do with your practice and how you might want to move this forward. So I think hopefully the reason that you're all here at 7 o'clock in the morning in Las Vegas is that you also feel like there's some benefit to genomics and that there's a next step that we really have. And really at Illumina, we believe that genomic data at some point will be ubiquitous. We were just up at a conference in San Francisco yesterday, and the speaker had asked the audience, you know, who thinks everyone at some point will have whole genome sequencing or have data, genomic data in their record, and literally everyone raised their hand. The big question is when, and we know that it's not a matter of if. It really is when is this going to happen. But there are so many advantages that we've already started to see. When we look at people who are ready to have children, being able to provide them with more information around risks for disorders in their children, carrier status for different recessive disorders, being able to be more engaged with having healthy pregnancies, both in terms of pre-implantation genetic screening and diagnosis and testing during pregnancy with things like non-invasive prenatal testing. Being able to look at small children or infants and really be able to diagnose and treat undiagnosed and rare diseases much more quickly than we've been able to do before. Recently, a physician who came from Kansas City moved out to where we are in San Diego, and he's really pioneered a technique where you can actually he can do sequencing, come to an interpretation and a diagnosis in about 24 hours, which for babies in the NICU is critical. You know, every day that they spend is a huge risk. So we also know that we can guide drug choices with these different things. We can help to treat cancers and not treat cancer as one disease, but as Florence said, as many diseases, and really treat that individual's cancer on a personal basis. And really, again, make that move toward where you all are focused on, which is health and wellness, and really putting those patients at the center of treating from a point of wellness, not a point of disease. So that was really the mission when we developed our Understand Your Genome programs. We noticed that there wasn't a lot of adoption. We opened a clinical laboratory that did whole genome sequencing at Illumina in 2009. By 2012, we still weren't seeing a lot of samples coming in, and we didn't really have the product that we needed either. And so at the time, our group decided that really what we needed was some way to accelerate the adoption of clinical whole genome sequencing, and also to bring in the right people to start the conversation about why things weren't moving into clinic. So our mission in terms of UIG is to responsibly but urgently accelerate the adoption of clinical whole genome sequencing, really to improve human health. The way that we do that is through this Understand Your Genome program. Currently, for a price of $2,900, people are able to participate in the program, which is a one-day symposium, along with personal genome sequencing and a clinical report. They also get access to their data in something that we call the My Genome visualization application, and I'll show you all of this a bit later. And most importantly, it's an opportunity to join a community. We have about 600 people who've gone through UIGs at this point, and they range from all walks of life. We have venture capitalists, we have Nobel Prize winners in genetics, we have all sorts of different people who are part of this Understand Your Genome community and are really dedicated to moving this forward into clinical care. So we really think of it as more than a conference. It's really a movement to start making clinical whole genome sequencing more of a standard and to start solving the problems that may be interfering with that adoption. Now, the most important thing is that this is what we call experiential education. So one of our UIG alum and a very well-respected and famous geneticist, Howard Jacob, who's now at Hudson Alpha, has said many, many times that nobody's genome is more interesting than his, at least as far as he's concerned. And I think everyone really feels the same way, that if you have the opportunity to look into your own genome, you get a whole new experience than what you've had before. Our first Understand Your Genome Symposium was held in San Diego in October of 2012. And when we held that event, it was invitation only. As I said, we had really sort of the thought leaders, the key opinion leaders in the genetics and genomics community. So these are people who've been working in this space for years and years and years. Their whole lives are dedicated to genetics and genomics. And still, when they actually were able to hold their own genomes in their hand, many of them described it as really a very transformational experience because they grew up in the world where everyone said whole genome sequencing will never happen in your lifetime. And now, not only did they have their own genome sequenced, but they were holding their sequence in their hands on an iPad. And for them, that was a really moving experience. So, in order to give you a little bit of context in terms of how we've been able to create the UIG programs, it's really important to know that a lot of different pieces had to come together at the right time. And just to give a bit of background in terms of the movement of genomics, I think the first thing is really the product. When we go back to 2000 and the first draft of the whole human genome sequence was released, all we had was data. Even 10 years later, from our clinical lab, all we were doing was sequencing genomes and shipping off a hard drive that had the sequence on it to physicians and researchers who then had to take that data and do their own interpretation. And there are not many people in this country who are able to do that, both from the perspective of the technical aspects and then to be able to tie it into the medical and clinical pieces. But in a very short period of time, after we adopted this Understand Your Genome program, we were able to provide interpretation and reports back for 344 genes originally for our first program. Just about 6 months later, we expanded that to interpretation and reporting for 1,600 genes related to about 1,200 different disorders. And then recently, about a year ago, we expanded that even more. We added another 100 genes. We added a whole new type of variant, small insertions and deletions to what we tested for. And we also offered our first pharmacogenomics panel. And as you'll see later, pharmacogenomics, I think, is one of the areas that everyone agrees should be low-lying fruit and really is one of the more actionable ways that we can use our genomic information. When we look at the utility of this, that's another piece. And of course, everybody who is in medical practice has to look at what's useful. What is the clinical utility? Again, back in 2000, we didn't know. We were doing research on all of this. We had some ideas about Mendelian disease, but above and beyond that, we knew nothing. And then in 2012, Howard Jacob, who I mentioned earlier, actually was the first person to apply whole exome sequencing, looking at the coding parts of the genome, to a very, very sick little boy named Nick Volker. So Nick was about 3 years old at the time, had a long history of this very, very bad form of Crohn's disease or some inflammatory bowel disease. By the time he was 5 years old, he had spent about 300 days in the hospital, about 100 trips to the operating room, and had about $3 million in medical expenses, and was dying. There was nothing that they were able to do. And what Howard and his team were able to do was actually find the causative mutation, realized that his disease could be treated with a bone marrow transplant, and worked with his physicians to actually make that move to do the transplant. And Nick actually just a few weeks ago celebrated his 11th birthday. He's alive, he's doing very well. So all of a sudden, we were able to take the research data and move it into the clinical setting. And that really was the impetus for a lot of the movement that we've been able to see thus far. Now we're moving into personal genome sequencing, and more importantly, we're moving into population genome sequencing, where lots of countries around the world are actually starting to sequence their populations to better understand the genetic underpinnings of disease. The price is another key thing. Again, going back to 2000, we were talking $3 billion to sequence the human genome. And so I'm sure many of you have seen the very, very overused Moore's slide that shows that the price of genome sequencing has dropped dramatically in the last 10 to 15 years. About a year ago, or 2 years ago now, I think, Illumina actually announced a series of machines that allow you to sequence a human genome at large scales for about $1,000. And $1,000 was really always considered that tipping point. That was the place where we were going to be able to start sequencing people using it clinically. Now, you won't see $1,000 on my slide. And the reason for that is that the $1,000 is sequencing only. And when we talk about using this in care, we have to add on the interpretation. We can't just give patients data. We can't just have them looking at their individual base pairs. They need context for it, and we need to be able to provide that context. And that costs money and takes a little bit of work. But through subsidies with Illumina, we've been able to drop the price of the Understand Your Genome Symposium and that test to about $3,000, which is significantly less than what you would get in most places. So we're really able to use this for that educational experience. And the last thing is really this idea of community again. Up until now, only about 1,000 people, they estimate, have had personal genome sequencing. Not exome, not chips from 23andMe or Ancestry, but full genome sequencing. So we've had about 600 of those people go through the Understand Your Genome program. So for all of the really innovative people in this room, this is the opportunity to sort of come in at the very beginning. And that's really a key thing, because as we start to do this, we need more voices. We need more people from different specialty areas, from different walks of life, telling us what they need, what needs to be developed in the genome, and what's next for patient care. So we were really happy with our first event. We got some fantastic reviews from some people that we really respect quite a bit. And that really drove us to start doing more of these. And again, part of that was just knowing that even these experts in genetics were saying that this was a really fantastic experience for them because it allowed them to experience genomics in a new way, which was really through their own genome. Since that time, we've evolved into having about 16 programs. We have 3 more scheduled for this year, so we'll be at 19 by the end of the year. We've sequenced over 600 people so far. We've done events all over the world, and I think that that's really one of the things that we're proudest of at this point. We've done events with the Mayo Clinic and worked with their executives to do sequencing. We've done events with the University of Minnesota, where they actually got a grant to put their genetic counselors and geneticists through this sequencing program and report back on what it was like as a professional to be able to experience this. We've done events with nationwide sequencing programs, places like Qatar in the UK, and shortly going to Poland to work with their nationwide sequencing programs. So this has really been an opportunity to start educating around the world and again, to start pulling those different communities together. But it really brings us back to this question of why do we sequence healthy people? We know that UIG is great for an educational opportunity, but in reality, it's supposed to be a driver to sequence more healthy people, and that's still an open question. But I think that we're starting to answer that question as well. So Robert Green is one of our UIG alums, and he's a medical geneticist out of Harvard. And he, at the Forbes Healthcare Conference last year in December, gave one of what I think is one of my new favorite quotes, which is that the newest frontier is sequencing healthy people. The question of whether to sequence the sick has been asked and answered. And that was a really pretty bold statement for somebody like Robert. Even 3 years ago when I joined Illumina, I was going to genetics conferences and conferences with genetic counselors who were wringing their hands and wondering, should we be doing exome sequencing? Should we be doing panel sequencing and looking at all these genes? And what will we do with all this information and all this uncertainty? And just 3 years later, all of that has become commonplace. So now we're on the cutting edge of looking at the next group. And there's been a couple ways that we can do that. we need to look and see what is different. So most of you have probably heard that 99.9% of the genome is identical from person to person. So if we were to take the genomes of everyone in this room, we should only see about 0.1% of your genome that's different from one person to the other. However, most variation is actually shared as well. The issue is that it's not necessarily shared across different populations. So we did an event recently in Tokyo, and normally when we look at things like variants of uncertain significance, so variants in the genome where we don't have enough information to really provide good data, what we find in our Caucasian population is about 10% of our variants as a whole are variants of unknown significance. In the Japanese population, it was about 30%. And that's because we don't have as much information in that group. And that's one of the things that needs to start to change. So sequencing populations is really the next step to advancing precision medicine. As we get more information, as we start to learn more about what's different and what's normal in any given population, we're able to do a lot more. And I don't know why the slides aren't working right now, but there should be a picture of President Obama with a double helix right there, and that was from the announcement in January of the Precision Medicine Initiative. So now in the US, we are actually dipping our toe in the water of really looking at large populations, how we can engage people and really make sure that we're doing this in a way that uses the information from the community and that feeds it back to the community. We're also doing this by research, and the research is obviously targeting in a much more narrow way. One of the most exciting things, I think, is that we're looking at newborns in many of these studies, and Robert Green's study is one of those called BabySeq, where we're actually looking at parents of healthy newborns and offering whole genome sequencing. And that's really where we want to end up. The idea of every baby being sequenced at birth would allow us to really apply genomics to a lifetime, and that's, I think, where we're going to find the most benefit. And then the final way that we can approach this is really from a clinical perspective. So this is our campus in San Diego. This is Illumina. And right over there is the Illumina Clinical Services Laboratory. And this is where we do all of our clinical whole genome sequencing for our Understand Your Genome events. So this is just the beginning. We know that there's lots for us to learn, but we know that between the clinical initiatives, the research initiatives, and these large-scale population sequencing initiatives, we're going to very, very quickly move down that curve and be able to provide this to more and more people. That being said, for anyone who would be interested in participating in the UIG event, you're at the very, very beginning of that. This is really an experience for the innovators, for the people who really want to be on the leading edge and be part of that movement. And it's interesting because, all of you, I'm sure, have seen this graph a million times, but recently I read an article that also sort of highlighted the problem with precision medicine, and they were talking about the fact that technology also usually has an additional curve where people go from enthusiasm to disappointment to impact. And the reason behind that is that most people initially overestimate what we're going to be able to do with technology, and then they actually underestimate it. And the point with this article was that with genomics and precision medicine, it's probably really not an issue of disappointment, it's really more an issue of impatience. Everyone's ready for this to happen. And we've seen it happening in some areas. We've certainly seen it happening in cancer treatments, we've seen it happening with pharmacogenomics, but everyone's ready for it to happen on a broader scale. And that's what I think we're really trying to focus on pushing forward at this point. So if there's one message that I leave you with today, it's that whole genome sequencing should be a resource. It's not a test, and a lot of people think of it as a test. When you do a test, you do it once and it's done, right? The idea with whole genome sequencing is that throughout your lifetime, you should be able to go back to that data and revisit it and ask new questions. And so what we did is we took this resource and we applied a test to it. And that test is what we call the True Genome Predisposition Screen. And this was a test that we developed specifically with the idea in mind of looking at healthy adults and trying to report back on what they may be interested in. So we know that people who are healthy may want insight into some symptoms, even if minor, that they have now. They may want to look for predispositions to diseases that they may develop in the future so that they can be proactive and preventive about those diseases. They may want information about their children. We know that certainly when we talk to adults that their first question usually is, okay, well, what does my genome mean for my kids? And we know that, again, drug choices are a very challenging thing, and we know that genomics can really be a benefit in guiding drug choices. So these four things, I should say, are really the core of how we built this predisposition screen. I mentioned before that we look at 1,691 genes. We now know that there are about 25,000 genes in the genome. So why are we only looking at such a small number? Well, part of it is because we don't know what a lot of those genes do. But part of it was because we also wanted to make sure that we were providing really responsible education. If we're using this as an educational opportunity, we really want to make sure that we have very well-established relationships with genes and diseases. So we looked primarily at Mendelian disease, classic genetic diseases, again, things that people might be at risk for, that they might be carriers for. And we really followed the guidelines of the American College of Medical Genetics and Genomics as closely as we could. When we take our approach, and when you'll see the variants that we look at, we really try to classify them into very specific categories. And I although there's 6 categories on this slide, I really think of them as 3 major categories. At the very base is where most of the variation in your genome lies, which is what we call benign or likely benign. And that really means that there's no strong association of those variants as causative of disease. This middle category is what I mentioned before, that we have these variants of unknown significance. And these are the things that will get geneticists and genetic counselors wringing their hands and freaking out about trying to provide this information to patients. Les Biesecker, who's a geneticist at the NIH, loves to say that geneticists are the only people who are afraid of their own technology. And it's absolutely true. You will never see a more conservative group of people than people who are working in genetics. And what we found is actually when we start talking to patients about variants of uncertain significance, and we say to them, hey, look, we know some things are associated with disease, some things are not, and there's a section in the middle that we're still learning about. They're actually completely okay with it. Us as providers are the ones that have the problem with it. So what we have to really learn is how to use these, how to talk to our patients about these, and then how to track them over time. Because we know that most of the variants of uncertain significance in your genome are probably normal variants, but some of them, one of them out of 1,000 might not be, and those are the ones that we need to keep track of. And then we have a category that we really focus on, which are these pathogenic and likely pathogenic variants, which means we do have strong evidence that they're tied to disease in some way. Now, I think the other thing to point out here is that when we talk about things like pathogenic and benign, we're sort of looking at this very black and white sort of definition. And the reality is that there are a lot of what we would consider benign variants from the perspective of traditional genetics that actually do have some impact. When you look at things like the genome-wide association studies and risk alleles for heart disease and hypertension, they're common variants, and so we would usually in genetics classify them as benign, but what we're actually learning is that those actually do have some impact when we start to add them all together. And again, that's one of those big opportunities that we have in front of us to start to really define how many of these variants and in what level contribute to complex diseases like heart attack, stroke, hypertension, common cancers, things like that. Why does one smoker get lung cancer and another doesn't? Those are the questions that we're really trying to answer with a lot of the other common variation. That's not, unfortunately, what we're able to do with this test right now, but again, that's the direction that we're moving in. And the reality is that we can actually find a lot in a healthy genome. Initially, we didn't really know what we were going to find because people didn't sequence healthy people. It's just not what we do. What we actually ended up finding, we just recently published, did a poster at 2 of the major genetics conferences and looked at our data. We've done at this point, had done 627 of these true genome predisposition screens in our laboratory. We clearly have a very skewed population in terms of the people who've participated in our UIG events. So 89.8% of the population that was studied were UIG participants. The vast majority were male and Caucasian. And so we are certainly looking at ways to expand out to get and touch more people and be able to get a broader population and broader sample. But what we actually found was that 38% of that group had a result that we expected to be clinically significant for them. In addition to that, almost everyone had a variant that caused them to be a carrier for a disease that could impact their children or other family members. But 38% seemed extremely high to us initially. And when we really dug into the data, what we found is that there's a lot of common genetic disease. Things like factor V Leiden, prothrombin mutations, a lot of the clotting disorders, hereditary hemochromatosis, very, very common in the general population. And so it's not surprising that we would see these things in our healthy people. But we now have a perspective of exactly what we're going to see. And what's great about that is if we're sitting in front of a patient talking to them about this type of testing, we now can say, these are the things that you're maybe going to come up with. The other thing that I think is particularly interesting is right up here. There's about 7% of our population came back with a very specific variant in a gene called CHEK2, which is a cancer susceptibility gene. It doesn't dramatically increase your risk for cancer like something like BRCA1 or BRCA2 does, but it is an increase, and it has been associated with things like breast and colorectal cancers. So this is a very common variant, 7% of our population, but we do know that that 7% does potentially have that higher risk. Now, do we do colonoscopies at an earlier age? Do we do them more frequently? Do we do breast MRI in addition to mammograms? Those are the questions that we do still need to answer. So how we approach this clinically is not only going to be determined by what we see in the genome, but the personal history, the family history of that particular individual. So we don't want to look at genomics as a bubble. It's not a crystal ball. It's really more of a roadmap that tells us what we should be focusing on with our patients, what questions we should be asking in regards to their personal and medical or family medical history, and where we should really guide our attention when we're taking care of them. The other thing that we did was to look at a set of genes that are sort of generally referred to as the ACMG 56. And so about 2 years ago, the American College of Medical Genetics and Genomics got a lot of people hand-waving again, and basically said that if you're going to look at an exome or a genome, even in a sick child, there are certain genes that you should always look for. So for those who may not be very familiar with how we approach looking at a genome, you can basically bioinformatically mask a lot of information, and when you get information that goes to your geneticists and genetic counselors for interpretation, there's a lot of things that they don't need to see, and so if you don't need to look at it, you don't look at it. What this said was you need to look. You need to look at these 56 genes because these 56 genes are conditions that are highly actionable and can have really dramatic consequences. So BRCA1 and BRCA2 fall into that list where we know that we can do a lot of prevention around BRCA1 and BRCA2. We know that if we identify those patients early, we have a dramatic benefit for mortality. And we have very well established guidelines on how to take care of those patients. Things like hereditary arrhythmias and cardiomyopathies are other things that are really common in that gene list. And those are all things that you can be very actionable about. So we actually found that 3% of our population actually does carry a mutation, a known mutation in one of these 56 genes. Now again, 3% doesn't sound like a lot, but when we're talking about 56 genes out of 25,000 genes as a whole, you can really imagine that as our knowledge grows, that number is going to get a lot higher, especially in terms of some of the actionable things. And the ACMG is already working on an expanded list. I can tell you that Robert Green's group on the BabySeq project, when they're looking at their list of genes that they're going to report for newborns, it's about 700. So this list is going to get much bigger, and we're going to see many, many more people being able to benefit from identifying these actionable mutations early on. Pharmacogenomics, again, is really one of the other places that we've focused on more recently in our Understand Your Genome population. The pharmacogenomics panel is something that we've only been using for about a year. And so for our last few events, I actually have taken the data and looked to see how frequently are people coming back with things that in common drugs could actually be actionable. So in this table, what I've got is 4 common drugs, so clopidogrel, tricyclic antidepressants, simvastatin, and warfarin, right? So these are all drugs that you absolutely can expect to see in a large group of people. And what we found was that a huge number of people actually have abnormal metabolism for one or more of those drugs. So if you look over here, every place where there's a different color is a different, one of those cases where there's abnormal metabolism. Only 2 people in this group didn't have abnormal metabolism for those 4 drugs. They did have abnormal metabolism for other drugs, but just not for those 4. So almost everyone in this room, in this group of the event we just did with the ASHG, has something that's potentially actionable. And it's really being able to identify those things and then tying them in that gives us the opportunity. At one of our other recent meetings at the Mayo Clinic, I was actually going through reports and sort of QCing them for our presentation in our My Genome application. And one of the things that I noticed was this one particular woman was a homozygous factor V Leiden carrier. So this is a woman who's at a significantly increased risk of having a blood clot sometime in her lifetime, particularly as she gets older, after pregnancy, or after any major surgery. The other interesting thing in her case is that she is an extremely poor metabolizer of warfarin. And I think all of us know that the first thing that they're going to put this woman on if she gets a blood clot is warfarin. Where this is really significant is that if you look at the expected therapeutic dosing, the expected therapeutic dosing for this woman is dramatically lower than what you would have for a normal metabolizer. It's 0.5 to 2 milligrams per day instead of 5 to 7 milligrams per day. So this woman should be started at a much lower dose. She should be ramped up much more slowly to make sure that she's not having any of those adverse events. Now, the way that our lab reports this out, there's a pharmacogenomics report and there's a clinical report, and they're on two different pieces of paper. I don't know if our lab knew that these two things went together. I don't know if her doctor knew that these two things went together. But when we were able to actually pull this into our application, you could see them very closely together and you could actually make that connection. And I think this is really where the biggest opportunity for clinician lies. If you're the doctor who's able to make that connection for that particular patient, you're gonna have a patient for life. Because not only are you really able to identify that for her, you're able to identify that for her family. So for this woman, any children that she has are automatically carriers of the factor V Leiden mutation. So you're not just diagnosing her, you're diagnosing a lot of people in that family potentially. And that's really a huge opportunity when it comes to taking care of patients. For the first time, we're really going to be able to start making these links between genetic risks for disease, personal risk factors, drug choices, and really be able to tie all of that together for those patients. On top of that, one of the things that I think is most exciting about working in the healthy populations is that we're really also expanding the phenotype. So when we look at what a person is, what they do, what their bodies do, we're actually now collecting huge amounts of information with wearable technology, and this idea of the scanners that we're going to have, and these Band-Aids or little Band-Aid marker things that look at UV exposure and all these different things. We're going to be able to have this huge source of data around all of these people and be able to tie that into the genetic information. And again, when we talk about common disease and diabetes and risk factors, that's the data that's probably going to be able to tip us over the edge, because we just need huge quantities to be able to make some of those decisions. So the last thing that I want to talk about is really this, again, opportunity of holding your genome in your hands. And the reason I sort of reemphasize this is because I think it's something that even our experts thought was really important, but it's also, again, an opportunity for our patients. We want to make the genome accessible, and that's really the only way we're going to get patients really educated and engaged in using genomics in their care. So what we developed at Illumina was something called the My Genome Application. This actually started back in 2009, and our CEO, Jay Flatley, had been sequenced. He was the first person to be sequenced in our clinical laboratory, and he wanted to show off his genome. And he also wanted to make it accessible. He wanted to be able to show people that this is not scary information. This is not information that you can't use. And this was right around the time that iPhones were becoming more popular. And so we actually did prototyping of an application where you could pull genomic data and actually, again, hold your genome on your iPhone. Since that time, we've developed it out quite a bit. We do now have an iPad application, but in our most recent developments with the web version, we're actually pretty much back to the starting point, which is this now runs on any web browser. And so again, whether it's on your iPhone, your iPad, your laptop, your desktop, you can actually have your genomic information right there. And you can imagine that people have problems with access and traveling, and if you're going to an emergency room and you have your pharmacogenomic information, or you're going to a new pharmacy and you have that information, being able to load it up on your iPhone is a pretty powerful thing. So what we have now is a web-based version of this again, and we can go all the way from the high level down to the very narrow level. You can actually go down to the individual bases of the whole genome. And this is really where we hope we're going to be able to provide more information to you, more information to your patients. So I'm going to actually end where Florence began with Joel Dudley. Joel is a great guy, and he has one of my other favorite quotes, which I think particularly might resonate with this audience, which is this idea that we need to go from wellness to genomics to disease instead of from disease to genomics to wellness. And that's really flipping the paradigm that we've been working with for a long time. So hopefully this has given you a little bit more of a background about both our Understand Your Genome program and really where genomics is going and how it can be implemented into your practice. And I guess I have a few minutes for questions.
Let me just add in the couple of minutes we have left. Thank you very much, Erica. That was brilliant. It really encompassed the field of what we need to know here. Yes. And I think we all can look forward to the May 12th symposium. We're going to be part of the AMMG is supporting this. They're the ones that brought this into the community here. For which I'm delighted. So on May 12th, which is day one in the new year, 2016 in Orlando, we're going to be running a full day symposium, and you'll hear more from Erica, you'll hear from Dr. Green, maybe even Dr. Dudley, who I intend to speak to, and hopefully ask Erica's help to do that. By the way, we didn't plan. Neither of us had any idea what we were saying this morning. So the fact is we are on the same wavelength, and we can see that this field is really beginning to emerge. We're going to be in the Donatello 3 room right across from the exhibits. We have a little bit of a jump start in that starting right away just to chat, but then again mid-morning, for those of you who are interested in registering, we actually have a phlebotomist here. We're going to be able to put your sample in if you're ready to go. I'd encourage all of you to do it. It was an amazing experience for me and two of my physician associates who came with me to the Baltimore meeting. We learned an incredible amount, and since then, all my patients want to do it. So if you have any questions, if not, we could disband and get a 15-minute break, but feel free to wander into Donatello. We'd be happy to talk to you more about what this means. Any questions? Okay, so we'll see you later. Enjoy the conference.